with noon conference, and folks who are on Zoom at noon, feel free to just speak up and unmute yourself if you want to contribute. Otherwise, just a reminder for everybody, school shops are due October 15th. Got it. On that one. No volunteers. You just hit got it, so that way that screen pops up. Okay. All right. So we're going to do a couple mini cases today. And then by the end of our mini cases, we'll build a framework on how to approach this topic. And so these are all real patients. First, we have case one. So this is a 56-year-old female. She has a history of pulmonary hypertension, hyperlipidemia, active tobacco use disorder. She's coming in to see you in clinic for an acute care visit after hospitalization for COVID. She was intubated, whole 9 yards in the ICU, discharged home, and is here to see you for hospital follow-up. She says that she still has some shortness of breath in addition to some headaches, some fatigue, some poor sleep. She doesn't have any chest pain, no cough, no sputum production, no lower extremity edema. And then you can see her past medical history there. So her pulmonary hypertension, she's got some HFpEF, hyperlipidemia, OSA, and question mark of COPD. It's in her chart from prior clinic notes, but there's not been active or new PFTs done. She's got no pertinent surgeries. For her social history, she smokes. She has a 40-pack year history and is trying to quit down to about 3 cigarettes a day. Drinks about 6 drinks per week. And then you can see her medications there. She says she's not taking furosemide. It was just an as-needed medication that someone had put her on previously. Any questions on that part? Okay, let's go down to her vitals and her exam. So she's 91% on room air, heart rate in the low 90s. Her blood pressure is about normal. Her respiratory rate is 18. She's afebrile. She's chronically ill appearing. She's got a regular rate and rhythm. Her JPD is elevated about 11 centimeters. She's got no lower extremity edema. She's warm and well perfused. And for her pulmonary exam, she has no increased work of breathing, just some mildly decreased breath sounds overall, poor air movement, and then also a large body habitus. And then, you get some baseline labs. You haven't seen her in a while. And so you get some blood work, and this is what you see. I'll zoom in. You guys can see a little better. So chat with your teams, talk about anything that's abnormal on her blood work, and tell me if you're going to do anything about it. What other tests you want, what other studies you want, or if you're just going to say, come back, I'll see you in a little bit. Take about, let's say, 1 minute with your groups.
They just
You can do it. You can do that same
All right, any volunteers for a table to talk me through their assessment of her current presentation? Okay, table 1. Take it away. Tell me what you guys thought about her labs, what you're worried about, what you do next. Yep. Okay.
We're worried about her polycythemia.
Okay, so her hemoglobin is elevated at 17.9. Nice catch there. What are you guys worried about in terms of her polycythemia? How do you think about that as a topic?
Generally, I think about, is there any respiratory underlying disease, or are they more concentrated, or are they, she's the rock, fructose, but a lot of them have been testosterone.
Yep. Yeah.
So
Okay, so Elizabeth is saying, do they have a respiratory issue going on with some hypoxia? Do they use testosterone if they're male? Perhaps under the table? And then do they have some sort of hemoconcentration going on? Anything to add from the other tables?
I feel like primary versus secondary.
Yeah, perfect. So the question is raised of how do we think of primary versus secondary polycythemia? And I would say a lot of Elizabeth's topics fall into that secondary category. So medication, hypoxia, or hemoconcentration. And then Evan, just to sort of call it out, what would be the issue with the primary polycythemia? Yeah, so an actual bone marrow disorder. Great. So you see this patient. What are you guys going to do going forward? So we already called out her polycythemia is the issue that we're worried about. So take about 1 minute with your tables and talk about any labs, other questions you want to ask her, other studies that you want to do, and come back to me with a plan of how you're going to manage this patient that you're seeing in the outpatient setting. And maybe we'll go with this middle table here. Sam, just to catch you up, we're seeing a patient in clinic post-COVID, came in with some labs, found to have polycythemia to 17.9.
Oh, yeah.
Whatever the.
Sure. Yeah.
38.
Yeah.
Where it's producing it all
All right, so let's come back together. Do I have a volunteer from the middle table here to talk me through a couple of the other tests or labs that you'd order? And then we'll address some of the issues in the comments as well.
We could test EPO, so if EPO is elevated, that shows more like a chronic hypoxia picture, stimulating EPO to reduce more cell lines, and then if it's not, that could be more of polycythemia vera process. I guess we could also do like a JAK mutation.
Okay,
test.
so 2 blood tests I heard, JAK mutations, and then EPO. Table 3 are some of our seniors. Anything else that you guys would do for this patient that you're seeing? Louder?
I mean, I think right now you could start by like trying to walk her and see if she gets hypoxic.
Yeah.
After the secondary path without having to like, get more like lab work and stuff.
Great.
And then kind of pending that, or maybe even if you're just like suspicious already, which I think given her symptoms, I would be suspicious that she has some sort of like lung issue or like obesity, hyperventilation or something like that, like PRTs. And then probably just ask her some questions. Try to think about like sleep apnea and just see if she's having any symptoms. Sleep study. Sleep study.
Great. So Logan pointed out, maybe we don't have to jump up to this $1 million workup just yet. We can get some more information. She has a lot of things in the category of respiratory issues in terms of her past medical history. And so perhaps we just get a little bit more information that way. Table 1, anything else that you guys would do differently or add to her workup?
Is Dr. Albert's mentioning getting supine concentrations? I think he's trying to get at like shunt pathophysiology. So. that's an interesting idea.
Yeah, and then just to read some of the comments out loud for you guys in the room. So Dr. Chan is saying, what's the cause of her chronic pH? You know, she has not had a full workup done. I'll say that it's attributed to the fact that she likely has OSA and possible COPD, but she hasn't had recent PFTs and she hasn't had a full workup due to some issues with insurance and just making it to clinic in time. Logan had asked, what's her BMI? It's about 38. And then Dr. Albert is saying, it's more correct to say erythrocythemia because only one cell line is involved, therefore not poly. And then asking how much weight did she gain in the last 36 months? And then lie her down supine and repeat the SpO2 measurement. In terms of weight gain, she's actually been fairly stable with her weight, so it hasn't really fluctuated much more than about 3 to 5 pounds, either up or down over the last couple months in clinic. Okay, so I love that you guys are thinking about some of this. Let's tackle what Logan wanted first. So an ambulatory O2 sat. You have the nurse walk her in clinic, and as she's ambulating, her oxygen saturation goes down to 86% on room air. And so she was discharged from the hospital without any sort of oxygen for COVID. She's been doing well, but clearly, some things maybe happened, and she now needs oxygen to be able to maintain her SpO2 greater than 90. So excellent point there. So she needs O2. PFTs are ordered. Those are still pending. And then questions about OSA. So she does have a CPAP machine. She's not been using it at home. And so that's something that we talked about to increase her compliance with using her CPAP. But like all of you guys, I also was concerned. I went back and looked at her CBCs. This is like one of my actual clinic patients that I still see and take care of. And, when I think about polycythemia, I also think about it in this primary and secondary way. And for her, just knowing her history of COVID, smoking, sleep apnea, she's got a lot of issues with accessing the healthcare system and like utilizing her medications and therapies appropriately. So I was pretty convinced it was going to be a secondary polycythemia with her respiratory history, but I still sent off an EPO level to see what that was. I did not jump to JAK testing right away. And so her EPO level is cooking, let's say, and just to sort of prove to you that this was an actual issue she was facing, if you went back and looked at her hemoglobin, she'd got as high as 18.2, and she was about like 18 the couple months prior. And so this really stood out to me because what happens to a patient who's hospitalized for COVID with an ICU stay? What's usually an issue? Yeah, phlebotomy. So you're getting lots of labs, they're being poked and prodded a lot. And so the fact that she was so, had such a high hemoglobin level on discharge, only a couple weeks after seeing her, after her hospitalization for COVID, I was like, this is not normal. We need to further work this up and see. And then, EPO level is pending. We'll have her come back in a couple weeks. So let's say about 2 weeks later, she follows up with you. She's been using her oxygen. Her SpO2 is now 93% on 3 liters nasal cannula in clinic. She's able to ambulate and maintain her sats above 90s. And we get some labs back. Anybody want to take a guess at what her EPO level is? Okay, we're having guesses for low. Yeah, so Nico is right. Her EPO level was 86. So that is a high EPO level. And what does that lean us towards? Secondary polycythemia or secondary erythrocytosis in her case, because only the hemoglobin's affected. But do we stop there? What are some other things that can cause an EPO level to be high? Yeah, take about a minute and a half and chat with your tables and brainstorm what are some other things that could cause a high EPO level. And then we'll come back together and chat. Okay, let's come back together. So high EPO level, we're worried about a primary respiratory issue in this patient, given her medical history. But what are some other things that you guys would be worried about or could consider on your differential? An EPO secreting tumor. Any thoughts about specific things? Yeah, yep. Yeah, so Sam is saying that renal cell carcinoma can do it. Dr. Chan agrees with you, so it's a good spot to be in. Dr. Chan is saying RCC, but most likely related to inadequately treated hypoxemia, cause to be determined. Does she also live at a higher altitude than Denver? She lives here in Denver. Okay, Logan, I think I heard you say something else, a different tumor type.
I think he said clear cell.
Okay,
We were just trying to think of any other tumors, and we couldn't really come up with anything. We were just guessing maybe another tumor.
yeah, yep. So I'm hearing lots of good responses in the room. HCC, breast cancer, those are all accurate. And Dr. Albert also agrees with you guys. HCC and breast cancer can also cause elevated EPO levels. Okay, so do you think that we should test everybody who has an elevated EPO level and figure out if they have HCC or renal cell? Evan's calling for a CAT scan. What are some things that you could look at in her past medical history in EPIC to figure out if she needs maybe a further workup for RCC or HCC? You just shout out whatever you would look at if you're the one who's, chart stalking her and trying to figure out your next plan of attack in clinic. Yeah, so does she have a history of cirrhosis? She drinks about 6 drinks a week. Prior had a more elevated use prior, but it's cut back. Does she have any prior imaging? So she's not had any specific like triple phase scans of her liver in the past, but there's never been a nodule or anything that's been seen. And then she's had some kidney imaging a couple of years ago, but nothing recent. There was nothing seen on that. Sort of playing off of prior imaging, we also have prior labs. And what lab would you look at, Sam?
Look at platelets and sodium for evidence of cirrhosis.
Perfect. So look at her platelets, look at her sodium. Platelets have been fine. Sodium's been fine. What's another lab that we could look at?
You can see like when her hemoglobin started going up, and it's been up for years. It's had no energy, so it's been fine. But uncertain.
Yeah. So we can look and see, when did this erythrocytosis happen? What's a hallmark of RCC? Yeah, hematuria. So you can go back and look and see if she ever had a UA in the past that would maybe warrant further imaging or workup. And so you go back and you look at her chart and you see that she's had a bunch of UAs and she has had 3+ blood, RBCs anywhere from 0 to 50 on prior UAs. She's never mentioned overt hematuria to you, but you see this and you just sort of have to wonder, is something else going on? So what would you send this patient for if this was the picture that you saw? Elevated EPO level, elevated hemoglobin, and then prior history of hematuria, both microscopic and on the dipstick. She's 56. Prior smoker or still active smoker. Okay, just an ultrasound, CT abdomen. You could do any of those. So I sent her for a CAT scan to see if she had anything going on, and it came back normal. So exciting case to think through, but a quick overview of polycythemia for this patient. And so, for her, it's likely all respiratory driven. So she's still in the process of getting, stable access to oxygen, following up with hematology, and then also plugging back in with pulmonary to address her underlying pulmonary issues. Okay. Go ahead.
If she's now in her hypoxemia,
Mhm.
she should have an improvement. factors, but also, I know, think about when he's not managing with secondary
Mhm.
polycythemia, and he's also, he's eating phlebotomy and stuff, and there's also got like something wrong.
Yeah, so Noah's, I'm just going to repeat it for people on Zoom here. Noah is saying, you know, how do we sort of balance treating her? She now has oxygen, so hopefully that will improve her hypoxemia, improve her hemoglobin, but then does she also need phlebotomy or other stuff like that? We will talk in our next case about treatment of polycythemia.
And would you have gotten a CT if you didn't have hematuria?
I wouldn't have, but the fact that she, you know, she already had this like intermittent abdominal pain. She had some microscopic hematuria and like hematuria on her prior UAs. And so just to sort of round out your workup, you need to make sure they don't have evidence of renal cell carcinoma, HCC, you know, on imaging. You know, she had a very strong story to argue for respiratory process driving this and her hypoxia. But with that evidence, it's sort of hard to not check that, because if you miss a cancer, then you know, you have other stuff that you gotta deal with later on. Dr. Albert is saying she also needs nocturnal oximetry. That's accurate. She needs an updated sleep study. But I get this lady to do approximately one thing a month. So her oxygen was what we worked on. Okay, so here's one example. Let's go to our second case. So case 2. We have a 64-year-old male. He has a history of hypertension. He's coming to the ER with acute onset vertigo. He's not had any head trauma. He's not had any neck manipulations. He'd been feeling well prior to this event. He showed up in the ER and was feeling so dizzy that he vomited about 3 to 4 times. The ER gave him some Zofran, which did help improve his symptoms a little bit. But his vertigo is still persisting. Here are his vitals. He is hypertensive to 181. His heart rate is elevated at 100. He's breathing fine on room air. His temperature is fine. And so take about 30 seconds with your teams and talk about what physical exam techniques you're going to do on this guy. And if I could have each table tell me at least one specific thing that they would do for someone coming in with this vertigo. And then we'll go through what actually happened to him. And so we'll start with table 1 when we come back, and then just work our way down the line. And then folks on Zoom can obviously participate as well. But take about 1 minute and chat about what you do for exams. Okay, let's come back together. So table 1, tell me at least one thing that you would do on exam for this patient who's coming in with new onset vertigo to the ER.
We do the Dix Hall Pike and hints.
Okay, Dix Hall Pike and hints. So what are you worried about if you're doing those physical exam techniques?
So like a kind of determine it's like peripheral.
Yeah, perfect. Middle table, what would you guys do?
So like the neuro exam, look for focal deficits.
Okay, so a neuro exam looking for focal deficits. And then table 3, anything else that you guys would do?
History.
History, okay. I will give you more history. You could start us off. What other information do you want or need? So it started about 4 hours ago, acute onset in nature. He's never had any vertigo like this before. So it wasn't getting better, so he came to the ER. Continuous, yeah. No hearing loss.
Headache.
Mild headache, but nothing major.
What was he doing when I started?
He was just at home watching TV.
You are.
No URI symptoms.
Was he having profound associative non-abnormality?
Yeah, he's thrown up like 3 or 4 times here in the ER. The Zofran's helped a little bit with that, but he's still feeling, very nauseated.
When he walks, does he fall on one side?
He found it very hard to get up and walk with his
Did you
dizziness.
notice like one side or the other?
No. Okay. Who here has heard of a HINTS exam? Raise your hand. Okay, who here feels good about performing the HINTS exam? Nobody, right? And so, yes, so we do the HINTS exam when you want to rule out basically a posterior circulation stroke. Let's see. Ed Chan is saying, I may eat my words, but I was taught as a student that the worse the vertigo is to cause vomiting, the more benign the condition. I'll see if this lore is right. Yes, you will, Dr. Chan. Okay, so I don't have any videos of this exact patient, but we'll get our basic exam. So he's uncomfortable appearing and has been throwing up since he's been in the ER. He just really doesn't feel well. Cardiovascular exam, regular rate and rhythm. He's well perfused. He's got no edema. His lungs are clear. But we have some sample videos of patients because I don't have actual videos of this individual. And so the providers in the ER did a HINTS exam, just like you guys mentioned. And so for the HINTS exam, there are 3 different tests that you do. And so this first one is called the head impulse test. I'm going to play this video on loop, and I'm going to try and point out exactly the finding that you guys should look for. And so what you see is that you put your hands on either side of their head, you tell them to look right at you, and then you basically want to shake their head from side to side. And the thing that you are looking for is, if you watch about right here, you'll see that her eyes saccade to correct back to midline. And so I'll play it. And so see that movement right there? They sort of were to one side and then bounce back to the center.
To the right, perfect.
Yep, so she comes from the left to the right. You guys all see that? Okay. All right, so that is the head impulse test. They should not have to have their eyes bounce back to the midline. They should be able to focus on you if it is a peripheral cause of vertigo. Next part of the exam is to look for nystagmus. And so you can tell the patient to look to the left and to the right. If they're not able to focus, you can actually put just like a white piece of paper on the side of their head and tell them to look into that. But you can see here that she has this beating movement of her eyes, and it's bidirectional, right? Like she has nystagmus, whether she's looking to the left or to the right. And so that is a concerning finding, or you're worried about a central cause of this nystagmus. Do you guys see that there? The bouncing? Okay. And then the last thing that we do is called the test of skew. And so what you're going to do is basically put your hand over the patient's eye, and then you move your hand quickly from one side to the other. And if you see that the eyeball sort of like rolls up, that is a positive test of skew. And so this patient has it. See how that eye sort of rotates up on his right side?
And you just have them look at you.
Yep, you just have them look at you. And so you can see that his eyeball follows this movement, sort of rolls up. Everybody see that? Okay. So those are the 3 components of the HINTS exam. This patient had no focal deficits, like he could move all his arms and legs, he could get up and walk. And so something that you guys should always be aware of is that if you're concerned about a posterior circulation stroke, they will not have any abnormal like focal arm or leg deficits because that's not part of the pathway for the posterior circulation. And so this acute onset dizziness, the one thing that you always have to rule out in an older person who has some risk factors for a stroke is a HINTS exam. And so, and Anthony knows this, we had a patient that we did this on. And so I'm going to pull up just a little image for you guys. And so these are the tests that you do for the HINTS exam: head impulse, nystagmus, and test of skew. And so if you want to take a picture of this, feel free to. You can save it in your phone. There's an excellent video online that I stole these images from. If you just YouTube HINTS exam, you'll get to it and you'll see these same familiar faces that are representing our patient. And so is his HINTS exam normal or abnormal? He had all those findings that the video had. abnormal. And so what are we going to do for this patient who has an abnormal HINS exam with persistent dizziness? Yeah, and you're going to call a stroke alert and you're going to send him to the scanner. And so we unfortunately don't have the read from his initial CT, but he's actually at the university right now. And so he actually had bilateral cerebellar pica territory infarcts, left greater than right, with local mass effect. And so he had an acute stroke, acute ischemic stroke causing this dizziness. So let's scroll down. He gets some baseline labs. So all typical things that we see for our patients who come in with strokes. So we get a CBC, we get some coags, and this is in case they're a TPA candidate. Unfortunately, this gentleman was not. By the time his workup was complete, he was outside the window for TPA. We can see a BMP there. He's got some hyperglycemia. His A1C is slightly elevated, but nothing too crazy. Then you see his lipids. So
Summer, I have a quick value poll.
yes, yeah.
University. So do you guys need to get an INR before you give somebody TPA if they're like not on warfarin and you're not concerned or TAC or whatever? Yeah, so you don't actually need to. So they got rid of this as part of the criteria at the university. It's even Humbler that piloted this based on a lot of students that have been approved to put a TPA without an INR because it's delaying time to TPA so much when you get the INR come back. And so we should get it, like definitely order it, but just know that we actually at the university at least do not need to have that back and be normal.
And this is only in patients who are not on anticoagulation?
Presumably. Because I think if you're on warfarin, it's already relative.
Okay, so Dr. Knies sharing value pearls. So at the university, you do not need to get an INR before giving a patient TPA if they are not on any sort of anticoagulation. Dr. Albert, or let's see at the top. So Edward Chan says, yes, I'm eating my words. Dr. Albert says, what is the diff on the WBCs? And Dr. Chan is saying, tox screen, why the anion gap? And so Dr. Albert, could you maybe tell us why you're interested in the differential on the WBCs? If you want to unmute yourself.
So there's erythrocythemia again, but this time there's also neutrophilia or lymphophilia. So there's two cell lines involved. I want to know whether those are neutrophils or lymphocytes.
Yeah.
I'm concerned about hyperviscosity here contributing to his brainstem stroke. And I agree with Ed, there's an anion gap acidosis that we haven't explained yet.
Okay. All right, and so I'll say that his differential was neutrophil predominant, about 80%, and then it just like split between the rest of the cell lines. He had no lymphocytosis. What's the other cell line that you guys could look at if you're worried about a possible bone marrow issue in conjunction with today's theme? What was that? So his platelets are fairly normal, so we don't have to look at that, but in your differential for your WBCs, what are other things that you can look at? I think I heard someone say it. Not lymphocytes or neutrophils. What are some of our? Yeah, eosinophils. So you always want to look at eosinophils if you're worried about a primary bone marrow issue, especially in a patient with maybe some polycythemia. And so his EOs were 0%, mostly split between lymphocytes and neutrophils. Okay, for this anion gap, we still have some studies pending. He's not ingested anything. His salicylates are negative, APAP's negative, but further workup to come on that. So this guy comes in, obviously he's got a lot of stroke stuff going on. So he has this posterior circulation stroke that needs to be dealt with. But the people who admitted him were also concerned about his hemoglobin and his white blood cell count. And so hematology was consulted on this patient. But before we get to their recommendations, I want you guys to take a crack at what you would do when you're admitting this patient. So how are you going to manage him coming in with these with his pica stroke? What tests are you going to order? Perhaps before your consultant even asks for them. And then walk me through what you're going to do for him coming in with acute stroke. Take about 2 minutes. And then we'll come back together. We'll start with table 3 this time for your input on what you want to do. And then we'll see if maybe you guys ask for some labs that come up on our workup.
Down to the window for, what is it? Is it 124?
Yeah, I guess
We don't know.
Okay, let's come back together. Table 3, start us off. What would you do for workup of this guy who's coming in with acute posterior circulation stroke?
You can't check the serum viscosity, that takes like a week to come back. But you're thinking about thinking of EPO and Jack again. One for treatment, would we think about empirically doing a spot?
Okay.
Something like hyperviscosity is like the cause here, and there's something to act on, it's ischemic stroke, so scared like stroke care. But
Yeah.
it's also addressing like something that's like obvious on the labs and severe addressed
Yeah, and so we're saying
or something.
stroke care. Maybe I'll punch to table 2. What does stroke care mean? What is our usual stuff that we do for a patient coming in with stroke?
Like diagnostics, like that,
Yeah,
we get like an echo, carotid ultrasound, Holter monitor for AFib. Or we already got like this kind of all workout, which is the only thing.
yep,
Yeah, I think. We also talked about another potential treatment. We were like most worried about hyperviscosity as the etiology of the stroke.
yeah.
And we still do other things to rule out ischemic causes, but we were thinking about empiric flex for him.
Okay, so maybe plex. All right. How do you want your echo? What's the extra thing that you're going to ask for? A bubble. All right, table 1, anything else that you guys would do for this gentleman coming in with a stroke? Yep. Yep. PT, OT, SLP, great. Any other things that you guys want?
I like a smear, I think they're helpful, like this. Runs home, or any supplements, home meds,
Yep.
supplements, that kind of stuff.
All right, so excellent, excellent list of things. Dr. Albert says viscosity measurements are insensitive and non-specific and take months to come back. So a good theoretical thing for us to maybe look at, but maybe not something practical that we can do. And so let's see what happens to this guy. He gets all of the stuff that you guys mentioned. I'm just gonna drop in the info that we have from our neurosurgery colleagues. And so, this is basically everything you would ever need to do for somebody who comes in with a stroke. So his only risk factors that we know of were hypertension. His initial labs, his LDL is 110, his A1C was pending at that time, but came back at 7.4. So nothing's really screaming that he has this like terrible metabolic syndrome to drive the reason for his stroke. The other things they point out, so they agree with you that he should get an echo with bubble. We got the labs. They're recommending an aspirin 81 daily. They also say to put him on tele to look for anything like AFib. Nobody mentioned an aspirin and statin, but I know that you guys know that. He'll get blood pressure and neuro checks every 1 hour. He had a very large territory that was affected, and they were worried about progression in terms of cerebral edema for his stroke. And then he had routine NIH stroke scales done, any CT for any significant neuro changes. They wanted to monitor his CTs a couple hours after he came in. And then otherwise, they also mentioned a PHQ-2. So patients with strokes are at risk for depression in the setting of their stroke. And there are studies that show they do better if we treat their depression. And so you guys can read more about that. And then everything else was, as stated by you all. They comment on the CBC and they just say, oh, his white blood cell count is 20, consider an infectious evaluation. And so with his hemoglobin being so high, his white blood cell count being so high, hematology was consulted. And so when Heme saw him, they said, we should check an EPO, which is what you guys mentioned. And they also wanted to look at his general trend and his CBCs because he'd not been hospitalized in the UCH system before. So we didn't have a prior to compare to. And so over the course of the next couple of lab checks, he was still high in terms of his hemoglobin. His white blood cell count remained slightly elevated at this time as well. But this sort of persistent erythrocytosis drove hematology to consider something like polycythemia vera as a cause for his stroke. And so his EPO level came back. Anybody want to take a guess at what it was? Low. Yeah, how low? Pretty close. It was 1. And so we repeated it again. What do you think it came back as? 1. Okay. And so he has an elevated hemoglobin with a persistently low EPO. So this is like the real deal. What test would you guys want to send off now? Okay. So we want to send off JAK testing. What are you going to do if it comes back positive? Yeah, so if it comes back positive, we're like, maybe he needs a bone marrow biopsy, maybe he needs some treatment. What if it comes back negative? Yeah, so I hear Dr. Knie saying send off the other genetic tests, but I can't remember what the name of it is. So do you guys know what mutation this JAK test that we send off targets? It's okay. So test for this mutation, which is the most common mutation in patients who have polycythemia vera. 96% of them will have this particular mutation. But if this is not positive, the other thing you can test for is exon 12 to 14, which is a different mutation that can cause polycythemia vera. And so just important for you guys to know, like, what's the one thing that I can send off? I mean, both, or is like one sufficient? And so for this patient, they did send off this JAK testing on him and it was negative, which was very surprising. So they sent it again and it was negative again. And so now he has this exon 12, 14 pending. And so he could be one of those very rare individuals that has one in the 4% that has this exon 12, 14 mutation, as opposed to the more common B617F. So we know that hematology is very worried about primary polycythemia vera in this patient because of the stroke and his elevated hemoglobin levels with a very low EPO. And so now we have to think about what are we going to do for treatment that can be directed towards his polycythemia, in addition to all of the usual stroke care that we give these patients. And so I heard someone mention phlebotomy, other things that we could do. So we usually don't plex these patients. His hyperviscosity is driven by his polycythemia vera, as opposed to like the hyperviscosity in like AML, let's say, where somebody has like a bunch of blasts. And so they usually do not get plexed if they have just polycythemia vera. Yeah, fluids. Anything else that we could do? Okay, this is a good start because this is the stuff that you guys will be responsible for sort of thinking about and initiating. And so, yes, the patient can get fluids. We're going to give them phlebotomy, but what's going to be our target? Are you just going to be like, just put the IV in, let it drain out until he's better? What's the number that you're going to target for these patients? A hematocrit of 52. Okay, we have one guess. We'll do Price is Right rules. Closest without going over. Any other thoughts? 51. Okay, so we actually target a hematocrit of less than 45% in patients who have had some sort of some sort of like thrombotic event. So he's coming in with a stroke, and so he would benefit from having a hematocrit that's less than 45. And so you can ask the nurses to do phlebotomy, taking up about like 250 or 500 at a time, every other day or so until he meets this goal. Dr. Chan is saying, in regards to fluids, is it still true that glucose in IV fluids can worsen ischemic strokes? I have not heard much about that. I don't know if anybody else has any thoughts about it. Glucose in IV fluids, if it can worsen ischemic strokes. I haven't heard. I'm getting a bunch of no's in the room, Dr. Chan, but I can look into that for you. Okay, so his exon 1214 is still pending. It's a test that will take a while to come back, but I'll let you guys know if that is positive. But hematology saw this patient. He was in the neuro ICU getting standard neurosurgical care with this very large posterior stroke. He did get phlebotomy until his hematocrit came down. The other thing that they started was a medication called hydroxyurea, which is a very cheap and readily available medication that can help to decrease proliferation of those red blood cells. And so he got started on that as well because they were like convinced that he had polycythemia vera driving his stroke presentation.
So Cassandra, what I can find about glucose for Dr. Chan is
Yeah.
that obviously we know that hyperglycemia worsens stroke, so progressive hyperglycemia, absolutely. But then also we typically avoid D5W due to the risk for exacerbating cerebral edema.
Okay.
But I don't think that like glucose in and of itself
Causes the problem. Okay, so Dr. Chan, Michelle found out that D5W is avoided for cerebral edema, but otherwise regular fluids seem to be okay for patients who are presenting with stroke in this setting. Okay, we don't have enough time for our last case before we sort of wrap up, so I'm going to skip ahead. And so I remember as a resident thinking about polycythemia, and there is an up-to-date algorithm that you can follow, but to me, it usually requires a little bit too much knowledge about polycythemia vera to like adequately use, because it's like, do they have symptoms of polycythemia vera? And you're like, I don't know, like a headache is very nonspecific. And so maybe it's polycythemia or maybe it's their OSA. And so I just sort of broke down how I think about polycythemia for you guys. So the first thing that I always ask myself is the patient having symptoms that warrant urgent treatment? Because much like a lot of hematologic issues, there's an acute and like not acute sort of presentation of disease. And so our second patient falls into this. Yes, he had an acute stroke from his polycythemia vera. And so for him, we're thinking more about treatment. The workup will come, but he can have phlebotomy, hydration, maybe aspirin to help reduce thrombotic events, hydroxyurea, and obviously talking to your hematologist to see if there's further workup that's needed. But let's say, thinking back to our first patient, she didn't really have urgent symptoms. She had like, a headache that sort of came and went, but nothing was persistent. And so in those cases, I will usually check an EPO level. For me, that really delineates, is this a primary polycythemia or a secondary polycythemia? And so if it's low, you can send off your JAK2 testing. That's the typical 617 mutation that we look at. If that's positive, you have your answer. You can sort of continue on with treatment in conjunction with hematology. If it's negative, but you're like, I'm really convinced this person has a primary bone marrow issue, like we did for the second guy, then you can send off the additional exon 12-14 testing. These are all things that you can order in Epic. You can just ask us, your seniors, your attendings, the hematology consult service, if you can't figure out how to order this. So for those that have an EPO that's high, I ask myself, does the patient have any evidence of any sort of renal or like liver cancer? Those are usually the two most common ones that can cause this issue. The questions I might ask, like, are they having abdominal pain? Do they have prior nodules that I've seen on imaging? Do they have hematuria? Do they have a history of cirrhosis? That's really concerning for progression to like an HCC. If the answer is yes, you go ahead and do your appropriate imaging for whatever cancer you're worried about and appropriate workup for that. If the answer is no, then I ask myself, does the patient have other causes of hypoxia? So do they have a history of OSA, a history of terrible COPD where they're not wearing their oxygen? Do they still smoke? If the answer is yes, you do your respiratory workup and treat those underlying causes, address their hypoxemia to hopefully bring down their hemoglobin. And then the very last thing I ask myself is, could they have carbon monoxide poisoning? This is more of like an acute thing. They shouldn't have an elevated hemoglobin like forever if they have carbon monoxide poisoning. So I don't often think about this, but it's just something to not miss that you see in patients with elevated hemoglobins. If it's yes, go ahead and send off your testing for it. If it's no, and you've gotten to the end of this pathway, then you should probably just talk to hematology to figure out what's going on with this person. And so that's how I think about polycythemia when I am admitting patients with it or taking care of them. And then just very, very briefly, we won't fill out this chart because we don't have enough time, but polycythemia vera is a myeloproliferative neoplasm, or MPN. And so the other ones that we typically think about in this category are essential thrombocythemia, which is when your platelets are really high, and then primary myelofibrosis, which is when you produce some abnormal blood cells, but you also have increasing fibrosis of your bone marrow itself. And so those patients with like an anemia, those classic teardrop cells that you see, and it's considered an MPN. Most of these will have a positive JAK2 mutation. And so that is like the driver for these MPNs. If you needed to pick one medication as a proposed treatment for all three of them, what would you pick? Yeah, hydroxyurea can treat all of them. And so if you're ever asked or pimped on rounds for a patient presenting with one of these, just say hydroxyurea, you're not wrong. It's used in treatment of all three of these. For the rest of them, particularly myelofibrosis, we think about things like, should they get a stem cell transplant because they'll eventually progress to pure bone marrow failure. The other thing to sort of keep in mind for these patients with MPNs is that they can progress to AML. And so it's something that we watch out for them as well. So if they had polycythemia vera and they're coming in with new night sweats, they're losing weight, they're having low sleep bleeding, easy bruising, you'd want to check a CBC with DIF to see if they now have blasts or other things like that are in their circulation that warrant more urgent treatment. Okay, so we talked about a lot today. We did a little overview of polycythemia. We talked specifically about our workup for primary versus secondary and sort of how to go down that pathway. And in particular, we talked a lot about the HINTS exam and people presenting with symptoms or signs concerning for a posterior circulation stroke. And then touched very briefly on the treatment for these patients. So phlebotomy, fluids, a baby aspirin, and then talking about hydroxyurea or other medications as needed, depending on their etiology. Questions on any of this? Okay. Have a good rest of your day. Like I said, there are snacks in the K2 staff lounge, some coffee, some other things. We'll be back on track for normal lunch and all of that for the rest of the week. Of course. Thanks everybody on Zoom.